Yeah, we are like,
Yeah, good evening, everyone. So I wish a very happy Sankranti and a Pongal to everyone who is watching this. And I think, to continue with our series of master classes, we have always tried to kind of be more practical and the classes to be more useful practically for all practitioners in their day-to-day practice. And we also speak about the current trends and the advances to kind of cover a wide range of spectrum of topics. But to stay relevant back to the basics and the infertility practice, we are now back again with our one of the most, I think, confusing and a topic where nobody agrees upon. But I think Dr. Jay will throw some light as to how to choose the mode of administration of progesterone, or the route of administration of progesterone in today's topic. So over to you, sir. You can take it over.
yeah, I'll just share the screen. See if you can see the screen, Shilpa madam.
Yeah.
Okay, fine. So I think what is important that we understand whenever we are talking of route of administration of progesterone, that this luteal phase support, okay, the only situation where we do not officially require route of administration for progesterone, nor do we need to discuss, is in pure natural cycle FETs. Okay. Simultaneously, we don't ideally need to discuss this in pure letrozole induced ovulation induction protocols. Because supposedly, even if you don't give any progesterone in these two attempts, okay, it is not going to reduce your results. Okay. If you give, it is good only. But if you don't give, okay, then it is not going to reduce your results. This is in pure natural cycle FETs or second in letrozole induced ovulation induction cycle. Right? It is important to understand one very simple concept of progesterone, that progesterone is basically derived from cholesterol. Okay. It is basically a steroid. Okay. Which we get through this pathway of cholesterol. And whenever there is any form of steroid which gets administered, especially through the oral route. So we have two or three routes. We have oral routes, we have injectable routes, we have vaginal, we have dermal, and we have synthetic orals. All right. So this oral which I am talking of is basically your micronized oral routes. All right. So whenever you try and talk of this, the first thing what this unfortunate guy has to do, even if it is a sustained released capsule, it is to go and disintegrate itself in the stomach. Okay. Even if you know the coating is something or whatever, the minute it gets disintegrated somewhere here or even here for that matter, even in inside the part of the duodenum before it enters the jejunum or whatever, even if it gets disintegrated here, unless and until it sort of reaches the lower jejunum, if it disintegrates before that, it will have to undergo something called as first pass metabolism, and this first pass metabolism is going to occur in the liver, and liver really loves any form of cholesterol, and approximately 80 to 90% of that is going to get degraded immediately. All right. So from whatever dose you give orally, you can give 200, you can give 300, you can give 400. Okay. The available concentrate, which is then going to be available, is going to be only probably 10 to 15% of that. Plus, as we all know, whenever we are using an oral route, the problem is the patient is going to experience some side effects. And the most common side effect which the patient experiences is headaches and dizziness. Okay. And I'm sure you have seen it in your practice, even with sustained release capsules. All right. So, majority of the people would really not want to give an SR tablet orally. And I'll come to a reason that somebody may say that the patient don't prefer a vaginal route. That is why I'm giving oral. I don't really think that is any answer, because this is the, in all the forms of tablets, this is the least preferred. Okay. See, another thing, please understand, when you are trying to administer progesterone, basically the body would require somewhere between 400 to 800, okay, milligrams of micronized progesterone. Kindly don't give patient micronized plus injectable plus vaginal plus synthetic. So much is not indicated, because unfortunately the receptor which is present inside the endometrium is limited. So even if you give unlimited progesterone to a limited receptor, rest of it will have to be thrown out of the body. And for whatever purpose, if we may add more than two progesterones or three progesterones or whatever it is to jack up our revenues or whatever we do, I personally just think it is bad karma. Okay. So just look into that. Right. So now coming to injectables. Now, injectable is obviously administered in the two most commonly available formulations. One is oil based and another is water based. Okay. So in the oil based and the water based, the only difference is that the molecule is tweaked very little, very, very little. It allows for, a painless, hopefully, a painless method or mechanism of storage. But just remember, oil based is going to be stored better. Okay. Water based is going to be equivalent to oil. Okay, but it is not better than oil. So no study states that aqueous injectable progesterone is better than oil based. It is an equivalent study. So obviously, if you ask any old timer or anybody who has been into the industry, since a very early part, they will say they will prefer the oil based, even if the aqueous ones are less painful. Honestly speaking, oil based have some role, okay, especially in patients who are more than 37, 38 years old. Okay, injectables. And usually, what we have seen is ever since COVID has come, the frequency of these injections has just become twice a week. Okay. Otherwise, no, what you will see is that with this oil based injections, if you were to do a serum progesterone, okay, serum progesterone values will usually be more than 80 on the day of transfer. Okay, that is how powerful these oil based injections are. Big problem of oil based injections is pain and abscess. Okay, for people who have not seen abscesses, they must see it. It is an absolute sight to watch. Okay, that is just something which you should keep in mind. I will come to vaginals in a little while. Okay, dermal not easily available. Let me just put it that way. Not easily available at the moment. Okay, but it is going to be the next big thing. Huh? I'm sure it is going to be the next big thing. I spoke to somebody. In fact, I spoke to somebody from today. Okay, and they are launching something called as a progesterone perfume. Imagine, hmm, progesterone perfume. So nice, no? You just have to tell the patient, दो बार छाट लेना. Okay, and even if the patient does something extra inside that, you can't really blame anyone. But I heard that this is coming in the next 1.5 years to India. I was really, really happy to listen to it. Okay. But really, it is the next big thing. Okay. Then, when it comes to synthetic orals, it is something which we all love. And that is, I'll write the brand name. It's okay. The brand name here is Dufaston. And basically, it is a retrogesterone. The greatest advantage of this molecule is that it can bypass some first pass. Okay. See, remember, this guy is original. Okay. And then there are a lot of biosimilars which are now available in the country. But I'll just tell you one thing, the way in which the photon bombing is done, okay, for manufacturing of Dufaston is simply unavailable in any other country at the moment apart from Amsterdam. Amsterdam is not a country actually, so don't blame me on that. It is a part of Dutch Republic, which is Netherlands. Okay. This is the only country and that is the only plant which has this superb photon bombing technology. It's a very excellent and an expensive technology. For people who have not seen it, Google it. You will really like to see how it is manufactured. Okay. No other people have something which is similar, as a result of which they are called biosimilars, which are commonly available in India with wonderful offers. They may be able to maintain approximately 60 to 80% of the efficacy, but definitely are not as good as the innovator brand. Okay, so just keep that in mind. Otherwise, it is fantastic. People can use Dufaston 10 mg thrice in a day, isolated as luteal phase support. There are trials going on that. I don't normally do that. I use vaginal, and in vaginal, you have options which are in. Oops, sorry. In vaginal progesterone, just a minute, the drawing is loading. Yeah, in vaginal progesterone, you have options of tablets. So basically, that's vaginal capsules. Okay, you have options of gels. So I prefer the 8% gel, and I usually, for patients who are undergoing ovulation induction or IUI cycles, I ask them to put the gels in the morning. And for patients who are in the IVF procedures, we usually give a BD dose to them when it is indicated, especially if the weight is more than 80 kgs, it's a BD dose. And along with that, we give them progesterone gel plus Dufaston. So it's a combination. Dufaston is given to them BD, gels are given to them BD. Very convenient, no injections in the protocol unless the patient is more than age 37, 38. We add a total of 3 injections, oil based, and these injections are given at the time of embryo transfer. Okay, and that is just something which we must keep in mind. I also want to add a very, very important thing. Vaginal is the most preferred route. Gels are definitely more preferable than capsules because capsules have this vague sort of a discharge which comes out, and sometimes the patients are not very comfortable, especially if they do not happen to clean their vagina very nicely. That is just something which you should keep in mind because, especially in India, many women don't get into that habit of cleaning the vagina, especially especially the deep parts of the vagina so easily. And in that situation, what typically happens to the patients is that they may have a powdery brownish colored discharge, which is going to be happening especially after using these capsules. Okay. The commonest not complication, the commonest side effect of any of these progesterones, which is the least with Dufaston, which is retrogesterone, is constipation. And that is something which is commonly seen in women who are dehydrated, typically in an Indian situation, that any form of progesterone you are administering to the patient, there is going to be some amount of constipation which the patient will experience. So that is just something which you need to be careful about when you are trying to choose the route of progesterone. Can we standardize and give everybody the same route of progesterone? The answer to that question is an absolute yes. If you want to give orals, the best thing is to really give a retrogesterone single drug. No headaches are required. There are some people who are allergic to vaginal progesterone otherwise. In that situation, Dufaston is a brilliant product to give. Okay, just in case you don't like Dufaston or you are angry with Abbott for whatever reasons, in that situation, if you want to standardize one form of progesterone, then it has to be a vaginal gel. A lot of times people have asked this question to me that, how do you compare the vaginal gels which are available from abroad as compared to the vaginal gels which are available, which are manufactured in India? So please remember the vaginal gels which are available abroad just have a added polysaccharide. Okay, this added polysaccharide is basically a chemical coating which is available to line the posterior fornix. Okay, most of these Indian companies also have it. Okay, most of the gels which are manufactured in India are just actually manufactured by two companies. It's either Acumes or Olive. One of these two people are manufacturing. There are no like 500 people from whom you are supposed to choose. And these people are also exporting the gels and capsules which they manufacture to a lot of foreign countries. Okay, so it is just where you have processed and packaged your vaginal progesterone that matters. Another important thing in an Indian situation, progesterones, especially capsule or gel based things, should be kept, away from heavy sunlight. Otherwise, heavy exposure to sunlight or temperatures more than 30 degrees consistently is going to cause some amount of denaturation inside these gels. You will see sometimes, the capsules would have become very loose if they are exposed to sunlight. The gel coating above it just breaks. Okay. So just keep that in mind whenever you are trying to choose a vaginal progesterone. With that, I think I've covered almost every practical aspect of the different routes which are available. And I've also spoken for around 10 minutes, 15 minutes actually. And we'll try and answer two or three questions. So I think if there are no questions from the audience on this, Dr. Shilpa probably has
Yeah, yeah. No.
logged in. Oh,
Yeah, yeah.
she's logged in. Hmm.
Mm. It was quite simple and straightforward what you presented. So you say that in all cases you only choose between retrogesterone and vaginal gel. Okay.
Yeah,
So and when do you use the I know you don't like the oil-based injections. So when do you use the aqueous injections?
I don't use it, madam.
Not even any time in your practice? I mean,
No,
okay. Tell me, I mean, why did you say that you use oil-based progesterone injection in older women, like who are above 37? What is the rationale?
you know, I could be wrong in this theory. It is just a stupid theory of my own. In these elderly women, I feel, okay, for the endometrium to become and develop that secretory changes very nicely. Okay, this sustained peak of progesterone is very important. Okay, just in these elderly women is what I think, or elderly uterus. Let me just call it that way. Okay, this sustained peak of progesterone is very very important. Okay, this same sustained peak of progesterone also comes from other molecules like progesterone. This same sustained peak will also come from meprate, medroxyprogesterone acetate. Okay. But the thing is, we can't really use that for luteal phase support predominantly because of the androgenic effects. So whenever something has an androgenic effect which is coming, it is going to prevent implantation by simply causing vascular changes, causing apoptosis of the vascularity. So basically, we can't really use that. Otherwise, the only thing which is equivalent to that is an oil based progesterone, and that is why sometimes I think it helps, and that too we have reduced it. I'm not very confident about it. So we have reduced it now to just three injections. It is given on the day of embryo transfer to the patient. It is given 3 days after that, and it is given 9 days after that. Khatam. No further oil-based progesterones to any of the patients.
So this is along with the retrogesterone that you give and along with the
Along
gel that you give?
along with the retrogesterone. Yeah, along with the retrogesterone.
Okay. What is your thought on, see, sometime back there was this vaginal tablet like Sustain VT, Naturogest VT, or various progesterone with a vaginal tablet, not the capsule.
Yeah,
But it is, I think, now taken off the market.
it's taken off the market.
Yeah. What was your, did you use it? I mean, where you,
In fact, I had written it to them that the disintegration quotient of a vaginal tablet is going to be very high because you are exposing it directly to the acidic mucosa in the
yeah,
vagina.
yeah.
Okay, and see, for something to directly get exposed to an acidic mucosa in the vagina, where the pH predominantly in Indian women is going to be approximately, between 6.9 and 7 point something. Okay, um, for that particular vagina. All right, unless it is infected, it will be something like 4, 5, whatever, bacterial vaginosis. But otherwise, that's the standard pH. So for something to go and act inside that standard pH, which is slightly acidic, you first need to go and neutralize that acid which is produced by the lactobacillus. After you neutralize that acid, only then that progesterone can get absorbed. Because this absorption is not going to occur because of progesterone receptors on the vagina. This absorption is going to occur because it forms a paste over the stratified epithelium of the vagina. And once it forms a paste over that stratified epithelium, the progesterone is going to be sort of taken inside by the cells and thrown inside the blood. Understanding? There is a mechanism for that. I've forgotten the name. Okay, but that time I had written it, that how that mechanism actually occurs. So the problem with these capsules is it will immediately go and the lactobacillus will only disintegrate it. So when the lactobacillus disintegrates it, it washes out because vagina has some of this rugosity, and with vaginal contractions that thing washes out. Because it washes out, it is not going to give a peak concentration, which is a sustained plateau effect of progesterone acting over the endometrium. And because that doesn't happen, okay, this is not so good.
Okay, so what is your thought on this extended release? There is a new drug in the market with extended release. So you think it's just like, a fad, or you think it's going to be useful?
See, what is the meaning of extended release? If you ever study how capsules are made, what is the meaning of extended release? One, the absorption for anything which is extended release has to occur throughout the tract of small intestine. Okay, it cannot. You cannot be dependent on something which is extendedly released in the stomach. That's not possible. You have to block the esophageal sphincter and the duodenal sphincter permanently for something to be having an extended release from the stomach, which is not going to happen, madam. Right? So the problem with most of these oral things is when they go, the acidic pH in the stomach is so high that it immediately disintegrates 90% of the progesterone the minute it touches that acid. Okay. And then there is no absorption because that absorption is limited, and whatever limited absorption is occurring, that liver will kill. Okay. Through the first pass mechanism. With sustained release, you are trying to bypass this effect a little. Okay. By reducing the acid, by ensuring that the coating gets disintegrated in the stomach and the progesterone enters inside the intestine. That is a thought mechanism. Okay, I think somebody was telling me that why don't we give anti-acid tablets along with this? Okay, so when we do that, the acidity in the stomach goes down. But the problem is the acidity goes down, but the pH is still 2.3 or something, 2.4. So I personally think giving these sustained release tablets orally is like, again, same thing. Trying to say that you have put the laparoscope inside and you are putting the light from the fifth floor instead of the OT. And then you are saying you operate in sunlight. ऐसा कुछ होता है क्या? You know?
Okay, so do you do progesterone levels after you give the progesterone in the like once you started on day 3 of your progesterone before ET? Do you do the progesterone levels?
Why are you laughing so much?
I'm sorry. Yeah, I'm sorry. Tell.
No. So we do progesterones on the day of embryo transfer for documentation purely. Okay.
Okay.
So we've had one, two, we've had total 5 legal notices so far on that. Such a big doctor, and he still put the embryo inside when my progesterone level was 4.1, 4.2, some nonsense. Okay, and that should not have happened. Should have been more careful as a doctor. Progesterone should be 25. All that bullshit. So basically nothing happens because there is no accurate way of measuring or correlating uterine level of progesterone with the serum level of progesterone, unless you have a corpus luteum. And these stupids forgot to mention that it was an HRT cycle. So in an HRT cycle, there is no corpus luteum. Only if you have a corpus luteum, you need a progesterone value of 25 uh, nanograms. If you don't have corpus luteum, all these values are time pass. Okay. And it is only and only done for documentation purposes. Okay. Even if you don't do it, is good. Doesn't matter. But yes, we try to tell people that even on the day of embryo transfer, if the progesterone is 0.25, That means the progesterone has not acted only. Okay. And at the time of starting progesterone, preferably the progesterone value should be less than 1, is what we tell. Though officially it can be less than 1.5 and you can start it.
Okay, so can you tell us like in oral progesterone and vaginal gels and in injection? So in injections, you told it will be always 80. So I have
Yeah,
been
very
a
high.
user of this injectable progesterone, especially the oil-based one, because the patients sometimes don't follow our advice, and we have had problems. So the first 6 days of the progesterone is always injectable progesterone from my side, and we see that the progesterone levels are always above 60 when we do it on fourth or fifth day of the progesterone level. So how do you assess these levels in cases of say when you give only vaginal capsules or vaginal gel or only
Can't
dydrogesterone?
assess. Can't assess. Retrogesterone, though, it is very, very tough to assess because it gets degraded into 3 or 4 types of progesterones, and then only one can be measured as serum progesterone, right? So, very tough to assess. Not possible to assess, honestly.
Okay, so you said it is only for medical legal purpose. I mean, do you
Yeah.
tweak the dosage in case if the patient has failed this time, so she comes back for a FET next time? Do you
No, no. It is
change
a
any?
separate endometrium. So, you don't need to really tweak anything. God has only tweaked it by shedding out that endometrium, you know? So, we need not really go and tweak anything. What is it? Laugh in all this.
Okay. You can't say all that. You should seriously answer the questions. Okay. In your practice, how difficult it is to like the compliance to be maintained. I know you have come out of this oral
Yeah,
progesterone, so that part is good enough. I mean, we don't use oral anymore, and Defestron is quite good, and it is quite, I think, a patient's compliance is quite good.
very
But
nice.
also vaginal gels, okay? So sometimes I feel that like, these patients are not comfortable, or for, I don't know, for what reason they don't use it the way that we tell them. So is there any way that you track the compliance in these patients, or what do you counsel them?
See, honestly, it is very tough to track. That is the first thing. Second, I think our culture is only such that, administration of anything through the genitals is not very commonly accepted as a part of our culture, be it per vaginal or per rectal, for that matter. Okay, that's not a very common or very, accepted thing for the patient. All right. We try to put majority of them on this single progesterone gel for IUI and ovulation induction cycles, as I mentioned. And that compliance is usually good, probably because of the uh, quality or the category class of patients whom at least I am entertaining. They would normally be compliant. Okay. But if somebody is facing these type of compliance issues, the best is to give the first one. It is oral, it will act. Even if you don't want it to act, it will act. Okay. And it has a very good peak and very good plateau, both the things, because it is synthetic. So that really solves the problem as far as compliance is concerned. Okay. But I still think I still think, okay, that the gel gives a much better endometrium as compared to only do first one. Okay, especially in IVF cycle. This is my thought. Though the studies don't concur with my thoughts, the studies say that Dufaston is equivalent. Okay, it doesn't say superior, it says it is equivalent. Okay, with the same outcomes. But this is just my thought. You had asked a question that, what is the best way to actually look if the progesterone is acting. So honestly, the best way is to do a pipelle biopsy. But then if you do a pipelle biopsy, you can't really do anything to that endometrium, any which ways. Okay. So honestly, there is no other way to assess the effect, because this effect of progesterone is only proven histopathologically. when we have a biopsy report which says progesterone effect on endometrium, which we commonly see for heavy menstrual bleeding patients in whom we have given registrol, right? We see that. So that's honestly the only way to see, but serum markers are not so great.
Mm-hmm. Okay, and costing wise, what is your thought? I know you do a lot of packages in terms of like IUI and IVF.
Yeah,
So for people who do packages also and who don't do packages also, so what do you think is more cost effective in terms of say when it comes to like the margin what we call in these drugs?
madam, it depends on your deal with the company. Really, it doesn't depend on the manufacturer, because the manufacturer is going to sell it to the company at a 7 to 8% margin, basically. And then it depends on you. If you want to go to Ashray, then the price is different. If you want to go plus Ashray plus ASRM, then the price is different. If you want to go to Ashray plus ASRM plus AICOG, then the price is different. So it really depends on what sort of deal you are trying to crack with the pharma company, honestly.
No, no, but you need to tell us, like, because see, Dufaston is quite expensive, don't you think? Like, when it comes to giving it TID for, say, like 15 days.
It
Uh,
it adds it adds approximately 2,000 rupees more to a cost of a particular cycle. Okay, if you were to add it exclusively in luteal phase, but
okay,
then I think it's okay. 2,000 rupees is fine.
okay. What about the Indian-made synthetic progesterones, which are like, enough and more of it is now overflowing in the market, right
Yeah,
from the top Indian companies to the
everybody has it.
everybody has it, and it's become so competitive that they say that buy one strip, we'll give you two strips free, three strips free, and all such like things. So
Actually, they can give the entire batch also for free. Honestly, you know why? Because majority of the companies, why? There's nothing to laugh. See, majority of the companies who have manufactured a biosimilar, they would. It's not that they are manufacturing one strip. Please understand. Every company has a loan license agreement to manufacture a batch. Okay, so the cost of manufacturing the batch to the cost at which it is being sold. Okay, there is a big difference. There is a huge difference, close to 80% margin, more than that actually, 100% margin, honestly. So what typically happens is, as and when the expiry of the batch keeps on coming near, uh, the offers keep on getting sweeter, something like that. You know. So I mean, you really need to be good friends with the guys who are manufacturing these biosimilars for all the other people. So you know who has manufactured what when, and then when it is 3 months away from expiry or something, or 4 months away from expiry, and if you want to experiment with all these things, then you can strike a beautiful deal, you know, and you will get it at the cost usually
okay.
because they don't want to dump it.
Okay, what is your thought on this vaginal capsules, the natural micronized capsules which you
It is
do?
good, but as I said, sometimes they have this powdery discharge which comes out,
Yeah.
and patients are sometimes not comfortable. The other problem with capsules is it has to be inserted with the fingers.
Mm.
Okay, or so nobody knows how deep it will go in the vagina. There are many people, I have heard at least, okay, who put it on the this thing external.
Yeah,
No,
I
no,
have.
really. People put I mean, they are unable to put it deep, so it comes in the lower one third of the vagina. So basically, people come with sort of vulvovaginitis because they are, that causes irritation there. So yeah,
I know, I know. So tell us this. See, if there is infection like chlamydial or candidal infections. So you think the vaginal gel, the vaginal capsules will work the same way? The efficacy
No,
will be the
no,
same?
no, 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 no. See, the rule of giving vaginal progesterone is to have a healthy vagina. So if in
So
case
do
you
you
have a
always give
fertility,
probiotics
you should
along
do.
with
Yeah,
uh,
yeah, yeah, yeah. Always
all?
on even on a healthy vagina.
Oh, so doesn't it increase the cost per cycle to the patient? Doesn't you add?
So it does, but I think spending on a probiotic is better than spending on the fourth progesterone, right? For the patient. So you might as well use justifiable progesterones and add a probiotic.
Yeah, yeah. Hmm.
And we do a high vaginal swab, madam, for a lot of
From
patients. Lot of patients.
when do you do that?
We do it at the start. I mean, we do it at the previous cycle. Like when people come after the oocyte pickup is done, and when they've come for signing on these embryos, at that time we just put a cusco speculum and do a high vaginal swab. Many a times we are doing a high vaginal swab even on the day of OPUs, on the day of egg pickup, for
Okay.
people who don't call.
What do you gain out of it? I mean, you send it for culture, and depending on the report, you treat them and then go ahead with the
Yeah,
FET.
but if somebody doesn't want to do all that, then the
Mm,
simplest option is to give them metrogel for 7 days. Okay,
mm,
and then give a probiotic and do it.
mm. So you see a lot of like this cervical erosion and which bleeds on touch, which you
Yeah,
recognize on the day of pickup or sometimes only on the day of transfers. Okay. So in
yeah,
such
common.
cases, the progesterone action, will it be different? Will it change anything to the patient?
Unless it is infected. So if it is just a physiological discharge through the ectropion, then
Mm.
usually nothing happens.
Yeah. Okay. Yeah, this was quite good. So thank you very much. I mean, it was an excellent session, giving us a lot of practical points to be incorporated into our clinical practice. So thank you again. Thank you everyone for joining us
Thank
tonight.
you.